Good morning, everybody. Thank you for coming to the third annual Synapse Roundtable. My name is Michael Graglia. I am the Managing Director of the Syngap Research Fund, and it is such a thrill to welcome our incredible speaker here today.
Hi, everybody. I'm sorry, I've lost my voice. I'm Geraldine Bliss. I'm the president and co-founder of Cure Shank and the mom of a 23-year-old son with Phelan-McDermid syndrome. And I'm delighted to introduce you guys to Dr. Kolevzon. He's a professor of pediatrics and psychiatry at Mount Sinai School of Medicine. He is the clinical director of the Seaver Autism Center and the PI of the Phelan-McDermid Syndrome Natural History Study in the Developmental Synaptopathies Consortium. Alex has a tremendous amount of experience in characterizing kind of the natural history of Phelan-McDermid syndrome and also in conducting clinical trials in Phelan-McDermid syndrome and other neurodevelopmental disorders. So Alex, thank you for joining us today.
Thank you, Geraldine. It's very nice to be here. I'm so sorry that you don't feel well. That looks and sounds painful. Maybe you need a blue muffin. This looked awesome. I was really glad I got to see that. All right, I'm going to share my slides. All right, can you guys see now my full screen?
Yes.
Okay, cool. All right, I'm sorry that I missed the previous whole talk, but it sounded like we were talking about sort of translational work from animal models to clinical trials in kids. That's also where our work started. I'm going to focus today mostly on the kids. And just talk a little bit about what we've learned in terms of the natural history and the phenotype of Phelan-McDermid syndrome, some of the challenges we face, and then a few of the ways that we're trying to address those challenges. So this may be redundant at this point, but Phelan-McDermid syndrome is due to SHANK3 haploinsufficiency. These are small deletions or mutations on the terminal end of chromosome 22. We know SHANK3 acts as a master scaffolding protein in glutamatergic synapses. We know it induces neuronal formation. It represents a potential target for treatment. These kids all have, profound global developmental delays, a whole range of dysmorphic features, none of which are specific. They all have language impairment. They all have some degree of intellectual disability. About 80% probably have, or 86% in this case, have low muscle tone. A lot of that is also related to GI dysfunction, as you heard about, probably the most common of which is constipation. Sleep disturbance is a really pronounced problem that affects kids profoundly, and also, of course, parents. And I guess this is an epilepsy group. So about 25% of these kids will have epilepsy. There's probably no specific kind of epilepsy or seizure phenotype. It's really all over the map. And probably up to 40% of kids, if not more, will have underlying EEG abnormalities without specific clinical correlates. And many will also just have non-specific histories of febrile seizures. So that's Phelan-McDermid syndrome. In 2013, Geraldine approached me and said, you need to put in a grant to study the natural history. I said, no way, we're not ready. She kept at it and paired us up as a Phelan-McDermid syndrome consortium with tuberous sclerosis and P10 or Cowden syndrome. And so we formed this developmental synaptopathies consortium, all around these synaptic genes. And our goal was really to comprehensively characterize the phenotype in children, adolescents, and now adults we've included, using a whole array of medical, genetic, behavioral, and cognitive measures. We really set out to add to the literature by doing prospective assessments to following kids over time, and to really sort of ensuring that what we understood about the phenotype, at least to date, was correct. We were very interested in tracking the natural history. Obviously, that's critical for developing clinical trials. We don't want to be picking symptom targets that are highly variable. And we want to be thinking about what are potentially tractable in the context of treatment. We were very interested in developing biomarkers, first using neuroimaging and now focusing more on electrophysiology, and I'll talk about that today also. And then the real main driver here is to develop new treatments. So we want to eventually start to assess safety, tolerability, and the feasibility of experimental therapeutics. We've done that in 4 or 5 different clinical trials, relatively small scale, all at a single site. And we're really looking now to kind of expand to leverage our whole network. So the network exists across now 5 sites focused on Phelan-McDermid syndrome. There's probably 10 sites in the DSC overall. But Mount Sinai, Rush with Latha Soria and Elizabeth Berry-Kravis, Boston Children's with Mustafa Sahin and Sid Srivastava, the NIH, the intramural program with Audrey Thurm, and Stanford with John Bernstein. We have collected data for about 140, 150 patients at this point, 90 in our first round, and we've now been funded for a second round. And we're doing baseline assessments, and we're following people out after 1, 2, 3, and now 4 years as well. So it's a really robust longitudinal study at this point. The second iteration, which was just funded, I think, 2 years ago, is now including kids that are younger than 18 months, or rather younger than 3 and older than 21. So we're really trying to capture the entire lifespan here. Well, one of the first things we've done, and we continue to add to it and refine it, is develop a kind of a standardized assessment battery. And we're really interested in a whole range of features from cognitive ability to adaptive behavior, language, motor functioning. One of the things that kind of unifies us is this autism phenotype, even if only about 60% of kids with Phelan-McDermid syndrome actually meet criteria. So we do a lot of digging into the autism phenotype, especially now around sensory symptoms. And then other kinds of behaviors, sleep, regression has become a very, very important area now to focus on, quality of life, of course, and any kind of longer term cognitive changes that might occur. So this is our battery. We recently published a study looking at the relationship between the phenotype and the genotype, probably the largest, at least prospectively collected study to date. And I thought I'd just put some of the features up that we now kind of established the prevalence where, as I said, hypotonia is probably the most common feature, gastrointestinal dysfunction, most commonly constipation, apraxia, ataxia, spine abnormality. So there's a whole kind of, broad and highly variable phenotype that affect people from, from 86, 90% of people, all the way down to 4 or 5%. I think dysmorphic features gets a lot of attention because it certainly alerts people to the concern and it triggers the need for genetic testing. But there's really no specific, I would say, dysmorphic features. Probably one of the more common ones and more unique ones to Phelan-McDermid are dysplastic nails. But again, nothing would be considered in any way pathognomonic. I guess I'll make a point also, I haven't seen it in the chat yet, but I'm sure Geraldine will ping me to do this. As it turns out, a lot of the epilepsy panels, so when you have a kind of a seizure phenotype and you order genetic testing, and there are a number of different sequencing panels that don't include SHANK3. So while chromosomal microarrays will pick up a large number of kids because of copy number variants affecting terminal 22q, you really need to do sequencing to pick up obviously smaller point mutations and sequence variants. So it's just important to be thoughtful about which panels you're ordering because SHANK3 is obviously one of the most common causes now of autism and neurodevelopmental disorders, even if not specific to epilepsy. So it's critical to think about exactly which genes are included in your panels. Other features include things like disrupted sleep, as I mentioned, anxiety. More and more, we're understanding now that kids at around puberty are really vulnerable to developing pretty pronounced neuropsychiatric decompensations with the emergence of symptoms that are consistent with bipolar disorder and even catatonia. It doesn't happen in all the kids, but the prevalence seems to be becoming greater and greater as we learn more. We're becoming more attuned to it. And then this issue of regression, although regression is characteristic of neurodevelopmental disorders and autism broadly, up to about a third of kids, it's certainly very characteristic also of a subset of people with Phelan-McDermid syndrome. And some of the things that I start here, which I wasn't going to cover very specifically, but there seems to be a relationship between the size of the deletion, where smaller deletions and point mutations are actually people that are at higher risk of regression. They may very well be because even at baseline, they have higher levels of language and higher levels of adaptive functioning perhaps, but they're more prone, of course, to also regressions. In terms of cognition and adaptive behavior, these are kids that are severely to profoundly affected for the most part. Obviously, there are people on sort of both ends of the spectrum, but for the most part, we definitely see this as a pretty severe intellectual disability. And we have a bunch of different language tests, including more objective tests like the EVT and the TPVT. Again, all of which just show pretty pronounced impairment, where only about half these kids are really verbal in any meaningful way. More than half are considered to be minimally verbal. And some of the importance of these measures is that they all represent possible tools to be using in the context of clinical trials. So to sum up some of the natural history, and I didn't present what the phenotype looks like over time, although when we've looked at it, it does seem to be stable to a large extent, with the exception of some standardized measures where we're seeing some growth into deficit just based on the comparison to typical peers. But in general, we're seeing that most of these measures seem to be relatively stable, and many of the tools that we're using are potential tools that we can be using in clinical trials because of their stability and just the test retest over time. So the natural history will clarify the phenotype for us, and I think we've done a lot to really better understand that and establish the prevalence of various features. I think we've done a lot to try to identify targets for therapeutic interventions, and I'll talk about some of the tools that we're using. Eventually, we hope to be able to identify demographic, genetic, environmental variables that actually correlate with disease outcomes, the ability to try to predict who's at higher risk of regression, the ability to try to predict who's at higher, who has sort of more likelihood of developing meaningful language. All these things are really critical in terms of just helping families and helping understand what the course of illness will be. And then we're also focused now on developing better consensus guidelines to establish both assessments, monitoring schedules, and then of course treatment, at least to the extent that we know about what works. And so we have a big working group now that's been developed across many different specialty areas, and hope to put out a consensus guideline sometime in the next 6 months. Okay, so that's the phenotype. And then in terms of the clinical trial readiness, this is really where we're all kind of so challenged, right? Because I think if we had the best medicine in the world, or even a gene therapy, perhaps, we wouldn't necessarily feel convinced that the tools that we have to measure change over time are especially sensitive or relevant specifically to Phelan-McDermid syndrome. So generally speaking, you think about clinical outcome assessments as either patient-reported, caregiver-reported, clinician-reported. You can combine instruments to create composite instruments, and then the ideal, of course, are like more objective tests. So in Phelan-McDermid syndrome, we don't have patient-reported outcomes, but we're still really kind of committed to trying to figure out, how to assess treatment benefit, right? And according to the FDA, treatment benefit is really determined by how a patient survives, feels, or functions as a result of treatment. And there are so many different symptom domains that really profoundly affects these kids and affect their quality of life. So we're really thinking a lot about across virtually all these domains, whether it's caregiver, clinician, or objective tests, to try to target specific domains and develop much better refined tools that are actually valid specifically to Phelan-McDermid syndrome. So one of the first things that we did was actually just took existing tools, right? So again, this idea of an autism phenotype is important to us. It's one of the things that unifies the developmental synaptopathies consortium across different genetic conditions. And the SRS is a very common tool. It's used in autism and neurodevelopmental disorders. It's one of the most commonly used one. It's also used in some clinical trials as an outcome measure. So we were interested in how it performed in Phelan-McDermid syndrome because we had a suspicion that it was not going to be especially relevant. And in fact, it really seems to have limited utility in general in populations with severe intellectual disability, including Phelan-McDermid syndrome. One of the challenges that we saw was that the majority of respondents endorsed really the greatest severity of autism. So there was a really pronounced ceiling effect. This is despite the fact that less than 60% of the kids met criteria for autism. We found that there was no significant difference between the mean SRS scores, whether you had autism or didn't have autism. So that was obviously a problem in terms of this measure. I think in 2017, Sturm developed a 16-item questionnaire that was a sort of a briefer version of the SRS, but it was supposed to be for people with individuals with intellectual disability, but still had kind of limited performance in our Phelan-McDermid syndrome population. So this was kind of what we predicted. It was a good sort of first pass in terms of assessing existing tools, and it was disappointing, although we learned a lot. And I think I've since kind of abandoned this particular measure in Phelan-McDermid syndrome. Another domain, in addition to autism and sort of part of autism really is sensory sensitivity. And more just based on our clinical experience, it seems that there's a relatively unique sensory profile within Phelan-McDermid syndrome, at least in comparison to idiopathic autism. So one of the other things that we did is just took the existing short sensory profile and did a comparison between Phelan-McDermid syndrome and idiopathic autism. And overall, we found that Phelan-McDermid syndrome kids actually showed less overall sensory sensitivity. And here, higher scores are actually more typical performance on this measure, as opposed to most measures where higher scores are worse. But in particular, we saw that there was a kind of a specific subset of the kids who had more sort of low energy or weak symptoms, or more kind of in general hypo-reactive. And that seems to be pretty specific to Phelan-McDermid syndrome. Well, not specific necessarily, but at least compared to autism more broadly, these kids have a lot more hyposensitivity in general. So some of this also led our group, and Paige Seiper in particular, who's our chief psychologist, develop a specific sensory assessment for neurodevelopmental disorders. So this is really the first assessment that's combining a clinician administered observation with a caregiver interview, and it's capturing sensory sensitivity. So if you think about the ADOS, in many ways this is mimicking the ADOS play, but tapping specifically into visual, tactile, and auditory sensitivities. It's appropriate for sure for use in severely affected and minimally verbal populations. Kids with autism show significantly more sensory reactivity symptoms on the SAND compared to typically developing kids, so we know that. And then again, when you look at Phelan-McDermid syndrome in comparison to idiopathic autism, we see that these kids are much more prone to hypo-reactivity symptoms compared to idiopathic autism. So this is thought to be now a beneficial tool for both research and potentially for clinical use. It's now been licensed, and there's going to be ways to kind of get trained up on it and use it clinically as well. We have a method of trying to test all of our measures, and both existing measures and measures that we're trying to develop in the context of clinical trials. So we will always be doing sort of pre and post assessments in the context of treatment. So one of the things that we did with our IGF-1 trials was we did the SAND before and after treatment, and we found that actually kids with Phelan-McDermid syndrome showed both significant improvement in sensory symptoms following 12 weeks of treatment, but in particular that improvement overall was driven by improvement in the hyperreactivity domain. So that was kind of an important finding for us, and has now led to a number of grants that have really embedded this tool in a much more consistent way. Just looking at the time. Oh, I have 5 minutes. Okay, maybe I'll skip this one. So the other types of measures that we're trying to develop use electrophysiology, both auditory event-related potentials, but also visual evoked potentials. So VEPs in particular are a non-invasive technique to evaluate the functional integrity of visual pathways. They're recorded from the occipital scalp in response to a contrast reversing checkerboard. The major, and let's see if you can see my, oops, sorry. You can see my mouse, right? So the major peaks, this N75 peak reflects glutamatergic activity, and the P100 reflects the kind of subsequent inhibitory response. So the balance between excitation and inhibition is reflected in this waveform. This is a very typical waveform of virtually anybody that's typically developing, and it could be an infant or an adult. But in Phelan-McDermid syndrome, what you see is sort of a massive attenuation of this N75 peak. And then of course, also an attenuation of the reflexive inhibitory peak. That's exactly what you'd predict based on knowing that the Shank3 gene is an anchoring protein for glutamatergic synapses, right? And so when you compare people with typically developing folks to people with idiopathic autism, to Phelan-McDermid syndrome, and even to Phelan-McDermid syndrome siblings, what you see is a dramatically reduced N75 peak. And so we think about that as a potential marker to hopefully predict treatment response. And the goal is to kind of match that up with clinical outcomes, specifically around the sensory domain. You can do VEPs pre and post treatment with drugs that we know act as kind of growth factors like IGF-1. And here in particular, the results show that improvement in the active treatment group, this is a very small subset, so this is very preliminary data, but improvements are seen in the beta and the low gamma frequency bands. So the thought is that this is potentially an important measure, and it definitely reflects the fact that there's increased excitation as a result of treatment with IGF-1. I think biomarkers are, everyone talks about biomarkers and they're ideal because they're objective, but they're only really going to be, I think, extremely useful if they're tied tightly to sensory or clinical symptoms in general. And so here, this shows that the kids with Phelan-McDermid syndrome show more visual hyporeactivity compared to idiopathic autism in typically developing kids, and that the extent to which that hyperactivity occurs is actually pretty tightly correlated with the magnitude or the amplitude rather of the excitatory peaks. So we do think there's a nice relationship between sensory reactivity, the VEPs, and we're showing also relationships between the SAND here, which is our sensory measure, and the VEP response, particularly around the glutamatergic peaks. So this just gives you kind of a little bit of a sampling of the kind of work that we're doing, the way that we're thinking about clinical trial readiness. There's many other groups and we have a lot of other tools that we're testing. But the hope is that once really viable treatments are available to test, we'll be ready with the right kinds of measures, and we'll certainly know enough about the phenotype and the natural history. So just to summarize, so we obviously want to be carefully phenotyping these kids, and that's, I think, what we've been doing. We've got a number of target symptoms of interest that we think have really important impacts on quality of life and clearly reflect the phenotype. Establish the natural history is an ongoing project, and we're starting to learn more and more. We want to refine existing clinical outcome assessments, and we want to develop some new tools. And of course, we have to develop and validate biomarkers, both as sort of a stratification tool, but also hopefully as a way to predict treatment response. And this is our team. This is way back when we were able to actually meet together in real life. I guess I'm happy to take any questions. Wow, I got it exactly in 20 minutes.
You nailed it. I don't know if we have a ton of time for questions, unfortunately, but I'm so grateful for Geraldine for inviting you to this, because I know Charlene and I are looking at this, salivating, and thinking about when we'll be able to see such rich data, and even dreaming about being a part of the DSC for STXBP1 and Syngap. So thank you so much.